This video presents a demonstration of an extravasation washout procedure. Extravasation injury is an emergency with which plastic surgeons commonly deal. It is a procedure that requires involvement from plastics and, when performed, plastic surgeons are often consulted for advice. Despite this, proper washout technique is poorly taught. In this video, recorded by plastic surgeons at the Guy's and St Thomas's Plastics Department, we're demonstrating the proper washout technique using a mannequin. This procedure was performed and recorded by Mrs. Jenny Gay, Mr. Ian King, Mr. Ross Wheel, and edited and narrated by Pranay Ruparelia. Extravasation refers to the accidental leakage of any fluid from a vein into surrounding tissues. When fluids such as systemic anti-cancer therapies, cytotoxic agents, monoclonal antibodies, or contrast agents infiltrate surrounding tissues, they can cause damage and necrosis. As a result, extravasation washouts are considered to be emergency procedures. We have set up a silicone right arm with a cannula in situ, next to which is all the equipment required for the extravasation procedure in the form of a pre-made pack. Key items include a scalpel, gauze, giving set, and fluids. Before starting the procedure, consent must be obtained from the patient, detailed medical photography should be captured, and appropriate PPE must be worn as per local trust guidelines. For demonstration purposes, the site of extravasation is illustrated in red and orange. Before the procedure begins, the site is identified and the borders and center point are clearly marked, in this case in blue. Once the site has been marked, the local anesthetic, a 20 milliliter mixture of lidocaine 1% and hyalase is prepared. It is vital to be aware that the maximum dose of lidocaine without adrenaline per patient is 3 milligrams per kilo. Going proximally to distally, the local anesthetic is infiltrated into the washout site. This acts to create a field block in the area. Additionally, the hyalase helps to dissect the subcutaneous planes to allow for the washout. Once the anesthetic has been infiltrated, the cannula is left in situ and aspirated to remove any extravasated content. By aspirating, we can also ensure that the correct horizontal and vertical planes have been maintained. Once the aspiration is complete, the cannula can then be removed. Next, clock face stab incisions are made along both the outer border and within the marked site using a scalpel. The incisions must avoid the veins and the known nerves and should penetrate through the dermis, entering just into the subcutis. We then used a red needle to create tunnels that allow all the incisions to communicate with each other. Once the communications have been created, the needle is linked to a giving set containing saline. In this video, we've coloured the saline slightly brown to make it more visible. The washout site is flushed through with a minimum of 400 milliliters of saline and then pressed at intervals with gauze to express the extravasated content. Ensure that there isn't too much resistance when flushing through, and that the volume infiltrated is in fact coming out. The purpose of the washout is dilutional. Once thoroughly washed through, the washout site is dressed with gelinette, gauze, and post-procedure, the hand must be kept elevated. Once the procedure is complete, the patient must keep the hand elevated and the wound must be checked within 24 hours post-washout. Remember that guidelines vary and local trust guidelines must always be followed.